Thank you very much for asking me to come and share with you some thoughts about this rapidly evolving situation. Usually, people who do ethics don't have the opportunity to speak about things that are happening in real time. Usually we're considering questions that have been around for 5,000 years and for which there are no answers. And so we get to cogitate about these in quiet rooms and in armchairs. But this is a topic that's dear to my heart in that it involves scarce resources, urgency, emergency, crisis, and panic, which is the butter for my bread. So I'd like to talk to you about desperation and desperate solutions. My talk, which I hope will leave ample time for discussion afterwards, is going to start off with some introduction and background, some of which may be known to most of you. So at the risk of boring you, you can just fall asleep for that part, and then we'll pick it up in a little bit after that. And I'm going to talk a little bit about desperation in general, and talk about some of the desperate solutions that people have suggested for dealing with the Ebola crisis, and then come to a conclusion that may tick everybody off, and hopefully by then you will have finished your meal so you can't throw things at me, but we can have a lively discussion at that time. So in 2007, I was a member of a task force impaneled by the North Carolina Institute of Medicine, which was charged with creating a proposal to ethically confront what was expected to be a major worldwide pandemic of influenza that could create havoc, fear, and deaths that might equal, if not exceed, those experienced in the great pandemic of 1918, 1919. And for those of you who are unfamiliar with the figures, the ballpark of the number of worldwide deaths over about a 2-year period was anywhere between 50 and 100 million. And it should be understood that this was at the backdrop at the end of World War I, where only, and I use that term somewhat advisedly, only 8 or 9 million people died. Any number of nightmare scenarios were proposed and considered, ranging from mild disruptions to schools and public services to overwhelming breakdowns of public order. Indeed, many of the smaller, localized events that have accompanied the spreading Ebola epidemic in Sierra Leone, Liberia, and Guinea, and to a lesser extent, as you'll hear tomorrow, much lesser extent, Africa's most populous country, Nigeria, such as riots and looting, were all anticipated as possible should influenza rapidly spread and incapacitate the fragile public health structure of the United States. One of the most challenging subjects we discussed was rationing of various health care resources such as vaccines, hospitals and intensive care beds, mechanical ventilators, and the roles and responsibilities of healthcare workers such as doctors, nurses, laboratory, and other technical personnel who would undoubtedly be stressed beyond imagination. These are big topics that are much too complex and involved to consider during this discussion, and I would be more than happy to share with you a number of references, both historical as well as recent, that discuss this. At the time, we also discussed how to confront the demand for existing medications that undoubtedly would rapidly become scarce. To let you know about the anticipated horror of pandemic influenza, one of the medications that we anticipated being in very short supply was morphine. And for those of you not in the medical field, we anticipated that morphine would be needed to calm the dying in their respiratory distress. And indeed, after about 6 months, we were finally able to convince Duke Hospital to stockpile morphine in a secure area in case we needed it. So in addition to morphine, we also thought we'd have a shortage of antibiotics and anesthetics, among a number of other medications. The central theme, in addition to having sufficient supplies to comfort the dying and the ill and the suffering, was also unfair allocation. However, we didn't need to consider the use of experimental treatments since influenza was not novel and we knew how to prevent it and treat it. However, another major area we considered was how to meet the anticipated shortage in healthcare providers, such as doctors, nurses, and lab technicians, whose numbers would be inadequate to meet demand, both because of the large number of patients and the possibility of widespread outages due to worker influenza. Would the crisis warrant lowering professional standards and expectations to permit, for example, dermatologists and psychiatrists acting as ICU doctors. Dr. Bartlett is laughing because
terrified.
He is laughing out of fear and terror, and because it never happened. But this was a central discussion that we had. The basic question was whether any doctor, and this theme will come up later, no matter how little skilled or knowledgeable in the care of very sick patients, was better than no doctor at all. Unfortunately, we were unsuccessful in developing satisfactory guidelines to regulate possibly dangerous practice, even when performed with the most altruistic of intentions. And for those of you who don't know, most states, if not all states in the United States, have a law called a Good Samaritan law, which means that if I am driving along I-40 and I see someone by the side of the road, I can stop and I can render assistance. And the Good Samaritan law reads that I will be protected from being sued because I did something wrong out of an altruistic notion. Now, it only goes so far. If I start trying to do things that are really off base, so for instance, let's say I'm an optometrist and I decide to try and set somebody's broken bone as opposed to simply dialing 911 and waiting for the ambulance, I could be sued, and quite rightly. That could be judged as negligence, not simply an altruistic wish to help someone. Now, Ebola is a different matter from influenza and presents challenges both similar to pandemic flu and those that are clearly unique. While there is little question that some supplies and materials may be in short supply to meet the demand as they are in the 3 countries already mentioned, it is likely, with the announcement of the world's response to this over the last 7 days, that the ramping up of the world's response to the epidemic will lead to minimal shortfalls of the most essential provisions, medicines, and facilities, so that the most difficult questions associated with prioritization and scarce resource allocation will not have to be faced. So I wish to concentrate on the second major area, which centers on considerations of whether standards of care, be they local, regional, or universal, are inviolate or may be altered to meet the demands of a crisis. The latter almost always involves a lowering of benchmarks of excellence or requirements of quality due to the desperation of the situation. The vindication hence hinging somewhat simplistically on the notion, as I mentioned before, that it is better to do something rather than nothing. If this view is adopted, then the details must be clarified as to what conditions would warrant such actions and how much of a departure from standard operating procedure would be too much. First, let me give you a brief background on Ebola virus infection, and I'm sitting here in front of an infectious disease expert, so don't hold me too much to the details, and the current situation. Now, I wrote this 2 days ago, so I can't say too much about what's happened in the last 48 hours. So when I wrote this, according to the CDC, there were about 5,500 cases reported with a mortality rate of about 50%, and this is consistent with previous outbreaks in West Africa. Ebola virus is a filovirus, so called because of its filamentous shape, observed on electron micrographs, and the other major member of which is the Marburg virus, which was initially discovered in the mid-1960s in an imported outbreak in Central Europe. There are at least 5 species of Ebola, of which 2 seem to be responsible for the most of the major epidemics to date. Interestingly, all of these have been self-limited and regionally localized. The virus is most likely endemically harbored in bats and possibly rats, and may cross over into the human population by ingestion of infected animals consumed for food. It is unclear what factor or factors trigger outbreaks, although there is some suspicion that it may be due to host features, in people that is, such as concomitant infection. Once resident in humans, Ebola is easily transmissible by contact with body fluids and is highly virulent. There is an asymptomatic incubation period of days to a couple of weeks, and patients then present with non-specific symptoms of viral infection, such as fever, malaise, myalgias, or muscle aches, that can then progress rapidly to multi-organ failure and a systemic coagulopathy, which is a coagulation problem, a clotting problem, similar to disseminated intravascular coagulation, which is a very serious problem. And the clinical picture resembles overwhelming sepsis. There was no specific anti-infective treatment or preventative vaccine available, and I'll talk more about this in a little bit. Thus, the approach to management is symptomatic. Ideally, this would include advanced intensive care as indicated. Not surprisingly, these kinds of labor and resource-demanding facilities, personnel and material are in limited supply in the locales most affected by the current epidemic. It has been suggested that the lack of public health and advanced medical ICU and other resources may contribute to the high fatality rate, and that more modern, extensive, and expansive hospitals and infrastructure, such as found in most developed nations, could lead to a much improved prognosis, although there is little evidence to support this conjecture. Most importantly, the most effective ways to prevent transmission and further dissemination is by standard, relatively straightforward, and usual public health approaches such as isolation, contact tracing, and quarantine, none of which requires sophisticated medical infrastructure, but do demand a level of on-the-ground intervention that has so far been unable to keep up with the virus. While there is a fear that Ebola could spread beyond the 3 countries most affected and move to Europe and the Western Hemisphere, Dr. Anthony Fauci, the director of the U.S. National Institute of Allergy and Infectious Disease of the NIH, has written, quote, "Although the regional threat of Ebola in West Africa looms large, the chance that the virus will establish a foothold in the United States or another high-resource country remains extremely small. Although global air transit could, and most likely will, allow an infected, asymptomatic person to board a plane and unknowingly carry Ebola virus to a higher income country, containment should be readily achievable. Hospitals in such countries generally have excellent capacity to isolate persons with suspected cases and to care for them safely should they become ill. Public health authorities have the resources and training necessary to trace and monitor contacts. Protocols exist for the appropriate handling of corpses and disposal of biohazardous materials. In addition, characteristics of the virus itself limit its spread." End quote. His statement emphasizes that appropriate and well-tested public health measures can contain and control the epidemic, notwithstanding the lack of effective antiviral treatments. Nevertheless, there continues to be a great fear that what has been to date a locally confined, although spreading and worsening epidemic, could easily spread to Europe, the United States, and Asia due to easy accessibility by air and sea, and thereby convert what has been a geographically confined epidemic to one that is widespread, if not global. Now, I should mention parenthetically, most people in this room look pretty young to me, and nobody feels as old as I am. But readers of a certain, or people of a certain age or interest in classic movies, and I recommend this to you highly, might recall or know of the classic 1950 film starring Richard Widmark and directed by Elia Kazan, which is called Panic in the Streets. Great film noir. Has anybody actually seen this besides me? It's a great movie. Widmark, a public health service physician, and so this actually is also somewhat of a historical movie because it actually demonstrates the United States actually had a functioning public health service at one point. He was stationed in New Orleans and was tasked with discovering the whereabouts and source of an imported case of pneumonic plague. The index case was a man who came off a ship docked in the port. So I would highly recommend this movie because it shows what happens when people get freaked out by these types of things. Certainly the media, and I'm not talking about a movie that's 65 years old, certainly the media has devoted time to this topic far exceeding its actual risk of occurring, thus hyping and stoking the concern. So at 9 o'clock this morning, I was in the studios of WUNC downtown doing a radio interview where the person who interviewed me is really smart and she does a great job, but one of the big questions was, what about when it comes to the United States? What are we going to do? So that's what people are freaked out about. And we can suggest, or we can discuss whether some of the Western response to this epidemic, and I'll mention about this more, some of this more a little bit later, some of the hyped up response of Western governments all of a sudden, seemingly, may be due to meeting fears that may themselves be irrational, that this could cause a pandemic in the United States or Western Europe. And by the way, the United Nations has declared the current outbreak a threat to world security. And I use those words, that's a quotation, a threat to world security, which in light of its current progression does not appear to be current public relations hyperbole. So the United Nations, the World Health Organization, everybody's all hyped up about this. It certainly could be a major danger to West Africa, especially if it's successful in spreading to Nigeria, and I think tomorrow we're going to hear why it may not spread to Nigeria. But the CDC's latest worst-case projections suggest that this, if it gets out of hand, and if confinement and Western intervention is not successful, by the end of January, something like 1.4 million cases could result, and if the fatality rate is still 50%, that's a lot of deaths. Now, for those of you who are interested, this is hot off the press. You can go to the CDC website and you can download this just published online edition of Morbidity Mortality Weekly Report, where all these projections, computer projections, can be found. However, in the absence of effective medical countermeasures other than quarantine and isolation and intensive supportive care, what can be done? Does the current crisis warrant loosening accepted and understood standards of care in a desperate attempt to stem the developing disaster? What can happen when people react precipitously in the midst of a threat of this kind, when their dread of what could occur amplifies their fear and could lead to decisions that may prove to be regrettable? There is a thin but often ill-determined border separating emergency situations from those breeding desperation, which itself can create further fear and even hysteria. Measures taken to combat the former, which can seem reasonable, can all too readily transform to less considered responses stimulated by desperation and hopelessness. So now let me spend a little time talking about desperation. What states of affairs are conducive to creating desperation in patients, their families, and the healthcare workers and their support systems personnel caring for them? It is important to recognize common features of situations that create anguished people in frightening circumstances where solutions do not easily present themselves, and extricating oneself is neither simple nor easily accomplished. One could readily imagine conditions in which one might be desperate, such as those that are both life-threatening and for which answers or fixes are wanting. When one is desperate, one is willing to try things to remove oneself or one's friends and family from the situation to a place of safety that would ordinarily not come to mind. We are familiar with tales of people who rise to the occasion and perform almost superhuman acts of courage and heroism on behalf of themselves and others when faced with no way out dangers. These stories almost always center on the central characters taking risks they would not normally even consider, all justified by the hopelessness of the situation and the fact that there was no other choice short of suffering the inevitable fate deeded by the terrible circumstances. Hence the audacious plan of the passengers on United Airlines 93 who stormed the flight deck in their last resort and successful attempt to force the plane away from its intended target. Hippocrates himself is quoted as writing, quote, "Extreme remedies are most appropriate for extreme diseases," end quote. Although I suspect he was not speaking of last-ditch interventions for which there was little empiric reason to believe in efficacy, but rather that very sick patients may require treatments that are themselves somewhat risky, but not necessarily unproven. Even so, it is fairly commonplace to utilize the language of desperate combat when describing the battle against advanced cancer or other serious and potentially fatal diseases. And when the treatments are unsuccessful, patients are frequently described as having lost their fight with cancer or heart disease. The doctors and nurses who care for these patients also adopt these warlike metaphors, and they are willing and can easily persuade their patients and their families to accept increasingly risky and toxic therapies in an attempt to extend life, sometimes at tremendous costs. Many view these audacious physicians as intrepid warriors ready to employ imaginative and creative means in bold strikes against an indomitable foe for which there are few, if any, proven and effective means of treatment. It is often claimed that the desperation of their patients and the grimness of their situations merit daring moves and taking any chances that may offer themselves to give hope where none may actually exist. But a cooler and more considered analysis may suggest that hope may not be worth the price to the individual patient and the potential damage to the social order of medicine engendered by a reckless use of intervention stimulated by terrible circumstances. Desperate situations may thus breed unwise, even dumb, and counterproductive or destructive solutions. So let's talk about some of these solutions taken under desperate circumstances and relate them to Ebola. One of the most commonly suggested desperate solutions, both in regular practice as described just now, or in situations where accepted and presumably proven effective therapeutic approaches are lacking, is to employ one or more of several different methods. They have in common the abandonment of the normal standards of care or research by which we regulate the practice of medicine and human subjects investigation to monitor the tension between benefit and risk. First, one could use previously untested medications or procedures, i.e. first in humans, that have presumably demonstrated some therapeutic activity, either in vitro or in vivo, in experimental animal surrogate systems. Second, one could attempt to repurpose previously approved medications, such as those endorsed by the Food and Drug Administration or the European Medicines Agency, for specific clinical indications as safe and effective, and for which there may be theoretical scientific reasons to believe they might have efficacy in the new clinical situation. There is massive experience with this activity as it forms the basis for much off-label use in the United States and elsewhere. Third, drugs that are currently under investigation but have not yet been approved could be either hurried along this regulatory path or taken off and used perhaps precipitously. And in the US, by the way, I should mention, this is probably illegal, as was the issue decided in a federal court case called Abigail Alliance versus the FDA. If anybody wants that citation, I can give it to you. It stems from 2007. However, there is ample precedent for this strategy under official circumstances, stemming from when it was adopted at the height of the HIV pandemic in the United States, under pressure from AIDS patient advocacy groups. However, there are definite drawbacks to this approach, as noted by many writers. Of course, all of these tactics must be viewed through the lens of being employed in third world countries that have a long and sordid history of being victimized and exploited in clinical research performed by developed world pharmaceutical companies. So let me consider each one of these methods in turn. It should be mentioned also at this juncture that due to the crisis, a hastily assembled panel of experts brought together by the World Health Organization, basically anybody who could travel at the time, endorsed the use of unproven investigational drugs under appropriate ethical guidelines. And they sort of talked about this. So the whole World Health Organization consideration for abandonment of standards of human subjects research in this crisis is 1.5 pages long. I'll be happy to send it to you if you want. You can get it on the World Health Organization website. They endorse the use of unproven investigational drugs under appropriate ethical guidelines, including transparency, fair access and allocation, and using the information obtained from their use to benefit others. As will be discussed in just a minute, these recommendations are both anodyne and meaningless in this context. It is important to understand that the world of drug development is in large measure a crapshoot. Even with the advent of advanced molecular modeling, supercomputer-targeted drug design, and the like, the percentage of pharmaceuticals that enter the development pipeline and then emerge as a fully formed medication that can be judged both safe and effective is vanishingly small. Indeed, the rate of approvals for new drugs has not improved much over the last 20 years or so. This means that our ability to predict therapeutic efficacy in combination with an acceptable margin of safety in humans is remarkably shaky. Not only is the forecasting success based upon chemical and biological data relatively poor, but proficiency at translating animal data to humans rests on a similarly shaky, unsteady foundation. Indeed, utilizing preclinical data to predict therapeutic activity in patients is a precarious enterprise and should be approached with all due caution. While the published information to date suggests that a variety of drugs, ranging from humanized monoclonal antibody cocktails, such as the now famous ZMapp, to small interference RNAs, or iRNA, to novel antivirals, are effective against Ebola or similar virus, such as the Marburg virus, in non-human primates, it is difficult to know what might happen, including unexpected toxicities, when these drugs are administered to people. Moreover, the supplies of these medications are so small that if the decision were made to go forward with using them in patients, one would then be faced with the challenge of deciding who amongst the thousands of potentially eligible patients should receive the few doses available. Finally, administering investigational agents in such a scattershot, random, but non-randomized manner would eliminate any opportunity to learn whether they were effective or safe. If a recipient got better, one would truly not know if he would have gotten better anyway. Conversely, if he didn't get better, he would never be able to tell if the drug was ineffective, or if he simply failed to respond, or if the drug was given at the wrong time. Finally, in addition, if there was suspected toxicity, the ability to ascribe it to the drug would be highly questionable. Finally, the risks of exposing patients to the unknowable would themselves be unknowable and therefore unacceptable, especially in those who are desperate and would therefore cling to any hope held out to them, no matter how unrealistic or even dangerous. In sum, nothing could be learned from this experience, and therefore no one in the future could benefit, and we would never be able to recognize if anyone in the present could benefit either. Similar problems present themselves with repurposing current drugs, mostly minus the unknown toxicity part, although one would not be able to know whether there would be unanticipated negative interactions with people who are infected with Ebola. Indeed, this might be not unexpected in patients this sick. In any event, using drugs off-label in this manner might seem to introduce fewer problems, but one is still left with the inability to draw any conclusions unless one used these medications within the confines and strictures of a controlled, randomized clinical trial. In the case of Ebola, since there is no existing effective treatment beyond supportive care, the control arm would have to be a placebo. It is distinctly possible that neither physicians nor patients would find such conditions acceptable, given that these drugs would be commercially available and thus could be readily obtained without having to enroll in the trial. Moreover, randomization of subjects is a difficult enough concept for people to accept under normal circumstances, but when the stress of life-threatening illness is added in, it might be found to be intolerable. Last, fast-tracking of investigational drugs that have entered the clinical trial pipeline, but for which little information on safety or efficacy is available, may be feasible, but it entertains many risks similar to the two other approaches. The only difference is that the study of the drugs in humans is a bit more developed, even though the hypotheses upon which they are being investigated may be comparably incorrect. Remember that many drugs that fail to make it to approval do so at all of the stages of development, not simply at the beginning, and it is almost impossible to predict where the problems will appear. Finally, the history of fast-tracking in the United States, especially with promising anti-cancer drugs, has not borne out the hope of providing more medications more quickly, as the limited success rate has remained virtually unchanged under this new program. The only difference is we find out faster that they don't work. As I have mentioned before, one significant difficulty that afflicts investigational drugs is the fact that they are usually only available in relatively small quantities. No responsible drug company is going to invest large sums of money producing vast amounts of a drug for which the odds would predict a hasty demise. Thus, the world supply of ZMapp was limited to enough sufficient to treat just a few people. The decision was made, and it is unclear by whom, to administer it to 2 American healthcare workers operating in one of the afflicted countries and a Spanish priest. The Americans recovered, the Spaniard died. Under ordinary circumstances, one could conclude either this process favored already privileged Westerners over their impoverished patients, or that it was believed that it was better not to expose Africans to the unknown risk of the drug and hence to exploit their desperation. Either way, we will never know if the drug was effective or if Ebola or the drug killed the Spanish priest because of the way in which the affair was conducted. Of course, one could potentially justify treating healthcare workers first, if one actually had access to an effective drug, as a form of reciprocity for their willingness to undergo the risks of constant exposure to infected patients, but this would have to be made explicitly clear to all concerned and earn their acquiescence, if not active endorsement, to be ethically sound. In the preparedness plans for pandemic influenza, priority for vaccine supplies was given to frontline healthcare workers, but the rationale was based on keeping them healthy so that they could care for the ill, not as payment for their risky jobs. And most of the plans for pandemic flu decided that doctors and nurses who got sick with the flu and potentially would need ICU beds or ventilators would not be advantaged over anyone else in a similar clinical situation. Once you were out of the fight, then you were like anyone else. So let me summarize. There is little question that the current Ebola virus epidemic is serious and threatens to spread and endanger the lives of untold thousands in West Africa and could pose a grave risk to the fragile economies of a number of already desperately poor nations. The deficient public health infrastructure of these countries has contributed to the ongoing crisis and no doubt has been instrumental in its regional expansion. Nevertheless, as horrible as this calamity is, it is taking place in an area in which there exist multiple endemic causes of premature death, including malaria, numerous diarrheal diseases, tuberculosis, HIV, and chronic malnutrition, to name but a few. While not discounting the tragedy of Ebola itself, the few thousand, and even for that matter, the potential 500,000 deaths that could result before the outbreak is checked, pale in comparison to the annual toll wrought by the regular mortal threats that occur as constant background dangers to the people who live in the region. As noted by Ridden Emanuel in a recent paper in The Lancet, the key to confronting and controlling Ebola lies not in yielding to emotion wrought by desperation and engaging in ethically questionable practices, utilizing not ready for prime time, or for that matter, even local access cable, drugs. Rather, the time-honored practices of public health measures such as quarantine, contact searching and tracing, and the like that we know are effective in infectious outbreaks and have previously worked with Ebola should be the first line of offense. When and if medications and or vaccines become available, they should be studied to determine their safety and efficacy as we would any investigational drug. We can thus learn which to keep and which to discard as either ineffective or too toxic or both. And even though apparently there is a vaccine trial that has just started within the last 24 or 36 hours, I think the story of vaccine trials for HIV should give someone some pause about predicting success. Things that look good in a test tube may not look good in people in the field. So we can thus learn which to keep and which to throw away. Furthermore, they should be studied in the population most affected by the epidemic. The companies making the agents should pledge, perhaps with financial and regulatory assistance of the World Health Organization, wealthy Western governments, the FDA, the EMA, etc., to make good treatments readily available and affordable to patients. Picayune squabbles over patents and profits should not prevent access by those most able to benefit, but perhaps least able to afford expensive first world medicines. Finally, it would undoubtedly be true that once effective interventions are discovered, it will take some time to ramp up production of a virtually unlimited supply. This inescapable feature of manufacturing should neither warrant shortcuts to enhance supply, such as releasing drugs before they've been properly tested for sterility and stability, nor holding on to existing stocks until there are sufficient amounts for all. Thus, there must also be an ethically justifiable rationing allocation plan for the first limited supplies. The best time to create such a plan is now, in anticipation of future success, and there are numerous published methods for how to create such plans. I fully realize that the strictures that I have outlined here may seem counter to our deeply felt intuitions and desires to do something, anything, in the face of the suffering of this epidemic. However, compassion and adherence to these ethical guidelines are not mutually exclusive. As terrible as this Ebola outbreak is, it is not the end of the world. Many more appalling threats to health and prosperity are endemic in this part of the world, and also deserve our empathy and compassion. But this fact does not license ignoring this crisis, nor does it sanction abandoning endorsed ethical standards simply because of desperate circumstances. Thank you.
So thank you, Dr. Rosoff. I'm sure this is going to stimulate comments and questions. Yes, Carrie. Maybe can I introduce Professor Carrie Stewart, who's also very interested in ethics.
So I have this, Phil, I told you I was bringing my class, and I'm teaching a class called The Ethics of Infectious Disease Control. And this afternoon, 90 minutes before you spoke, we looked at pandemic flu, and one of the students, the student group, presented their last slide, which was comparing pandemic flu and Ebola. So we really said, we walked right from class into your lecture, so it was very, very timely. So let me bait you in a very obvious way. So, I mean, there's two ways.
I think our time is up.
There's two things I want to engage with you on. The first is standards of care and treatment, and we'll get back to that after other people have had a chance to ask questions. But you've offered us a classic biomedical framework, which is embedded in philosophy and theories that are debated in the West. We're trying to apply these things to a situation that's evolving in a resource poor setting, where bioethics philosophies and theories have not actually been debated and don't have any sort of relevance at all, I would argue, in this case. So, and you offered three situations to sort of examine your conclusion. One is untested medication, number two is off-label, and number three is fast tracking. So number 2 and 3, I think, are really relevant right now, but untested and ZMAP is what I'm really interested in. So setting aside theory and philosophy, if your wife or your partner or your daughter or your mother was laying in bed and had 24 hours to live, she was sick with Ebola, and they offered you ZMAP, what would you do?
So Michael Dukakis lost an election supposedly because he couldn't answer a question about capital punishment. If his wife was raped and the rapist would he sentence him to death or something like that. So
but that's what
I'm not running for president. I think that one of the problems and one of the dangers from addressing substantive ethical and moral issues such as that is making decisions like that at the bedside. These types of situations require careful, and that doesn't necessarily mean slow, but careful, and not the World Health Organization overnight 1.5-page ethics discussion. Careful and considered debate about the wisdom of doing something like this. Asking me if I would want an untested medication for myself or for my loved one is not fair.
But hold a second.
It's not fair because you're baiting me. It's not fair because it's not fair.
But the decision has to be made. So
the decision has to be made, but not at the bedside. So if we take a group, not just like it is unfair for me to go see a patient and say, you know something, we've spent too much on ventilators this year. This guy shouldn't get a ventilator. Or we should take him out of the ICU bed because the healthcare crisis in the United States, we're spending too much on healthcare, and this is the way we're going to save money by taking this guy off the ventilator. Those decisions should not be made at the bedside for many of the same emotionally fraught, not well thought out reasons that you should not ask me what I would do with a dose of ZMAP for my loved one.
But some people were asked that question and had to make that decision.
And they were asked inappropriately, I think. That should not have been on the table. The fact that you had this medication that worked in rhesus macaque, and I don't know if anybody's read the paper, I believe it was published in PLOS ONE, 10 days ago. As much as I could understand, although I did see the table and of the rhesus macaques that got Ebola who weren't treated, and it was done against, and actually the placebo, I think actually was just no treatment at all, not just non-specific monoclonal antibodies or some other engineered monoclonal antibody. But all the monkeys, or 13 out of the 14, something like that, of the monkeys that got ZMapp lived. And none of the ones that didn't get ZMapp. That's very compelling. But if given enough time and given a computer and PubMed, I can show you how easy it is to cure advanced cancer in a mouse, but not in people. I can even show you how easy it is to cure advanced cancer in non-human primates, but not a mouse. We have vaccines for HIV that I believe work very well reasonably well in non-human primates, but they haven't worked so hot in people yet.
But really, you're avoiding answering my question.
Of course I'm avoiding answering.
The fact is that my argument is biomedical theories and principles are constructed outside of these situations in the West. We have a real life situation and people who are having to make those decisions. How do you advise that they make those decisions?
Why are we forcing them to make those decisions at all? Why? Who put ZMapp in their hands? How did they get it?
Well, that's a very interesting story.
That is a very interesting question. Who?
But irregardless of the upstream stuff, that moment of decision is what I'm asking about. And how do you
If
make
we
that
took
decision?
the approach that highly investigational agents should not be given to people if there is no reason to think in people that they will work, meaning that there's no evidence in people that they will work, how in the world would we ever release them in the first place? That option would never arrive. So let me give you an example. When I'm not playing ethicist, I play doctor, and I take care of children with cancer. So many of these kids are actually quite sick, and some of them actually go on to die. And there are a range of things that we could use with these children. I have adult colleagues and pediatric colleagues who do this all the time, but many people will not. I can't call up a drug company. That's not on the table for using an investigational drug. Does anybody know the Abigail Lyons case? This is what you should teach in your class. Okay, so Abigail was a 19-year-old young woman with head and neck cancer. And there was some early phase 1 data and test tube data that a drug called Erbitux. Now that drug is most famous for most of you because Erbitux was what got Martha Stewart put in a slammer. Okay? So because that was the drug made by her boyfriend's company. So this is an anti-EGF receptor antibody. And it showed, it was being tested against colon cancer. And there was an early phase 1 trial looking at other types of adenocarcinoma. She was not enrolled in this cancer. In this trial, she had advanced head and neck cancer. She sued the FDA and the drug company, but mostly the FDA, to release this drug. She sued in federal court. And the contention was that she had a right, because she was dying, to get anything irrespective of its investigational status. She lost at the district court. They appealed to the appeals court in Washington, to the DC Circuit. A 3-judge panel, 2-1, agreed with her. The FDA appealed to the 9-judge full court, and they tossed it out. And I think a very well-written opinion. They said there is no right, that the importance, not necessarily the sanctity, but the importance of the human subjects research apparatus, no matter how desperate the circumstances, does not warrant the threat to it, the integrity of it, does not warrant breaking it, because no matter how sad this story is, does not warrant breaking the system or threatening to break the system because of this case.
But there is no system in place in Western Africa.
Well,
So,
I would argue actually that there is.
All of these arguments just are
There used to be
not
no
relevant.
system in Africa, but because of some very nasty clinical trials that were done by Western drug companies taking advantage of people in Africa, we now actually do have a system.
Anyway, So I'm just trying to understand what your answer is. Your answer is,
My family let him die.
okay.
Yes, sir.
I'm curious, Miles, I really appreciate your talk, but some of these experimental vaccines anyway, even if they were to prove effective, isn't their transportation, storage needs, administration, it renders them basically impossible anyway for this region. I know of like ZMapp has to be stored at -20, transported that way, and then it's an infusion drip that takes 10 hours.
See, I can't
How's that gonna
speak
happen?
about the vaccine, but let's just say it's a simple vaccine like, name a vaccine that has to
Polio.
be refrigerated. That has to be refrigerated. Influenza. Polio has to be refrigerated. Oral polio has to be refrigerated. There are mechanisms of doing that. So depending upon whatever theoretical vaccine may or may not exist, if we can ship ICUs over to Sierra Leone and Liberia, we can probably handle that as well, if there were a vaccine that we're going to be studying. Now, if you're interested in history, and John probably can speak much better about this, but in the 1950s and the widespread polio vaccine trials were considerably different, and I don't know if those polio vaccine trials would be done the way they were done then. I don't know if they would be done today.
Yes, sir.
Yeah, so let me throw you another curveball. Hypothetical situation. Let's say you're on the interagency team.
We're not talking about a spitball, right?
Not a spitball, it's a curveball. You're on the interagency advisory team to the Joint Task Force Commander, 2-star general over there in AFRICOM right now. And he's looking for your advice. Him and the country team leader, the U.S. ambassador, we're going to advise the Liberian president on the next course of action. And currently, the situation is more people are infected, taking, we'll say,
Can I interrupt you
40,000.
for just 1 second? Why in the world would a U.S. ambassador and a 2-star general be advising on a public health problem?
It's been done. It's been done.
Just out of curiosity.
It's been
Because
done
it's
in
a
the past.
security issue?
So, but hypothetical, ZMapp, let's say, there's a more bigger correlation of that it does work in treatment. And they look to you for advice. They got 50,000 vials. Logistics is no problem using them. And they ask you, there's limited evidence or just a correlation that this works. There's panic in the streets right now. There's people are rioting. Social work's breaking down. Doc, what do we do? Do we use this stuff or not?
So you predicated upon this saying that there was some evidence to suggest that it was. So let me go back and say that first of all, I am not against all relaxation of standards. When we were considering pandemic flu, so I don't know, you may not have known about this, so that Tamiflu, which is one of the antivirals that can be used in influenza, has a shelf life of 3 years, I think, something like that. The pill form, not the stuff you inhale or you snort up your nose. The FDA gave permission to stockpile Tamiflu beyond its expiration date because there was evidence to suggest that it actually lasted considerably longer. Now, what happened to all that stuff when the pandemic flu never happened, or didn't happen the way people were concerned, they threw all the stuff away. The point I'm trying to make is that there is some reason and rationale to justify some relaxation of standards. I would argue that the evidence, or the suggestion of the evidence, that Tamiflu 2 years or a year past its written FDA expiration date, because of the way those expiration dates are devised, the evidence suggesting that it would work would be considerably greater than any evidence we would have right now with ZMapp. So let's go back to your question. You have 50,000 vials of ZMapp, and you have all of the accessory stuff that you need to administer it. So there's 2 questions that come up. One, what is the data supporting its use? Is it just the stuff that we decided to make this on spec? and we just have stockpiled all this stuff? Or is there some reason better than what we have now that it works in 13 or 14 macaque monkeys, that it would work in humans with acceptable toxicity? Besides John, anybody else here a doctor that uses infusional therapy? Giving monoclonal antibodies to people is not exactly the most risk-free stuff in the world. You can kill people this way. Okay? So just because, and who knows why the Spaniard died. We don't know whether he died of Ebola or whether we killed him with ZMapp. And just because those 14 monkeys didn't have any toxicity, at least that was reported in PLOS 1, we don't know. The other question is, let's assume for the sake of argument that you have enough evidence of efficacy to justify a reasonable departure of standards. So you're not going to, let's say you've done a reasonable trial. Let's say you've done a phase 2 trial in 100 patients. Fine. So you want to use it. Now it becomes a rationing and allocation problem. So who should get it? And how should it be allocated? And as scary as this sounds, there actually is a fair amount of stuff written on this, admittedly by bioethicists, but including at least one bioethicist who actually does this and wrote a policy for Duke Hospital on rationing scarce drugs. And we've actually used this policy, and it's been adopted throughout most of the United States at hospitals, for doing this fairly. Can it be done fairly in a resource-poor nation, which is stretched to the limit, where people are panicking in the street? I have no idea. Let me mention one other further thing, since you mentioned panic. In planning for pandemic flu, there was a very interesting study that was done when the CDC was going around the country doing focus groups to find out if the initial rationing plan, and this is particularly for vaccine, so this is for allocation of vaccine. It was thought that it would take quite a while to ramp up vaccines so that everybody could get it. The initial allocation said that healthcare workers should get it first, and which I think, since I'm a healthcare worker, I think was perfectly appropriate, so that they would be available to take care of patients. There were a couple of other people in that Tier 1 group, but one group that was not in that Tier 1 group were security people. So National Guard, police, firefighters, and people like that. And it's interesting that the focus groups said these are just plain old folks. Well, not plain old folks, they were people who would be willing to show up for a focus group. They said that you should actually prioritize security people because of the anticipated potential for panic, and that they should be treated first. So you could make an argument in that situation that if security people are dropping like flies, and that is why there is so much panic because order cannot be maintained, that maybe under those circumstances they should be considered to be privileged and prioritized.
But back to the first part, would that be a yes, use it, or?
It depends on, I would say it depends on what the evidence base is. Should we subject, if we had no evidence this is work, should we do a non-controlled experiment in 50,000 desperate Africans?
Yeah, great.
Let's say there's a little bit more evidence than we have now.
Hallelujah. We've given it to you and you lived. How many people, so a phase 1 trial usually has 30 people enrolled. Now a phase 1 trial is a toxicity trial. So generally speaking, the way these are structured, these people, patients or subjects, are created in cohorts of 3. You start at 1 dose, you give it to the first 3 people, and you guess what dose you should use. You guess what dose you should use based upon the animal data. And you start low and you start ramping it up, usually a 10 or 20% increase each dose. And when you get to the predefined dose-limiting toxicity or some unexpected toxicity, that's when you stop. And 1 dose below that is considered the maximally tolerated dose. The next study is a phase 2 trial, which is open to more people. And in this case, it would be open to presumably people with Ebola virus. And you might open it up to 50 to 100 and see what happens. Now, under these circumstances, would you do a placebo-controlled trial? I'm not so sure. That would have to be open to discussion. But if you had phase 2 data, or early phase 2 data, I think that would argue for using it. But then you have the more difficult problem as to who to give it to. And quite frankly, I find that more challenging than deciding when you've got enough data to give it. Because every person you give it to, there's somebody you didn't give it to.
Chrissy?
Thank you very much for your talk. I think my question is relatively straightforward. Just to clarify what you are suggesting that you've already told us. In the situation we already have where, as far as I understand it, we have very little evidence for our current drugs and vaccines because they haven't reached the stages. If I understand what you're suggesting correctly, it's that we should continue as we would continue to effectively research these drugs. What I'm not quite clear on is when you're going to do the randomized trial or whatever your study is, are you suggesting that we should do it within the emergency setting itself, or should we continue as if there was no emergency setting and look for another environment that isn't overlaid with the same problems to keep the clarity of the research?
I think that if it can be done, if the trial can be done in the population who would benefit from the outcome of the clinical trial, then it should be done. And indeed, it is more than reasonable that this is happening in West Africa, because it is in Africa and other resource-poor nations where many of the abuses of Western companies doing trials on drugs that would not benefit anybody in those countries were performed. And I think the World Health Organization rules on regulating clinical trials in resource-poor countries has put an end to that. So absolutely. If you can do it, absolutely. Now, the research human investigations enterprise often suffers from not having people who are willing to sign up. Now, going back to, you can Google pictures and maybe some old film clips of what happened in the 1950s for the first trial, the open trial of polio vaccine. There were lines down the block because people were so scared of polio that everybody wanted to volunteer. That's fine. There was enough vaccine for almost everybody in line. That's not going to be the case, certainly initially, for anything that comes out of this. Who should be allowed to participate in the trial? Now, you don't want the usual kind of people who sign up, for instance, for phase 1 clinical trials in cancer, because these people are not usually eligible for anything else, and they are so sick it sometimes is difficult to estimate toxicities. You actually want somebody who's got Ebola, but just a little bit. And that may be very hard to do, because that's the only way you're going to be able to find out if the Spaniard died of Ebola or you died of ZMapp, if you're so sick by the time you enroll in the trial. And my guess is that what would happen if you announced we have enough ZMapp, for instance, since that's what everybody wants to focus on, to try for 100 patients, 100 subjects to see if it works, that's where you're going to need the National Guard to keep people away who are going to want to sign up and be in it. Now, you could also add, by the way, that because of the desperation of the circumstances, is that free and informed consent?
Right.
Probably not. Any other questions?
Yes.
Okay, my question is, if we're trying to institute a trial abroad, what are some measures that have to be taken to institute that it be fair and accessible, since there is so much havoc and there is so much, there's so many people scared of the Western doctors and medicine, and how can that be sped up so that we have time for it to impact this epidemic rather than when we actually are ready to implement the trial, the epidemic is ending.
So let me see if I understand the question. Is how can you properly perform a trial amidst panic and disorder and all sorts of stuff like that? I think it would be very, very difficult, and I think I addressed that just then. How would you get people to sign up? How can you do free and informed consent? I think even under ordinary circumstances in resource-poor countries, this is a major challenge, particularly the fact that many drug trials often include medical care while you're on the trial. And there have been a number of questions as what happens, and for many of these people who enroll in these trials, that may be the only care they actually get. And now what happens when the trial is over, do the people who are conducting a clinical trial have any kind of responsibility to continue that medical care? Now, for some medications, there is a reasonable consensus that if the medicine is actually effective, so for instance, this happened with HIV trials, that they do have a responsibility for people who are on the non-control, the drug arm, to continue the medications, if not offer it to other people who are on the placebo arm, if there was a placebo arm, the control arm. Beyond that, we don't know. So how would you do it here? Let's say we have enough, let's say for ZMapp or some other, let's say for one of these repurposed drugs, or one of the antivirals. There's a company in, actually in RTP, Chimerix, that I just read about in the newspaper today, that has some antiviral, and I have no idea how this is supposed to work. It's supposedly an anti-DNA viral antiviral. Ebola is an RNA virus, I don't know. But in any event, they say in a test tube it works, and so their stock went through the air, through the roof, and now they're ramping up to try and do it, I guess, in monkeys or something. So let's say you have a limited amount of stuff and you have to give it repeatedly over a week to 10 days. But you only have enough for 100 people or 50 people. There are a number of challenges, not the least of which is the disorder and the lack of infrastructure, but a lot of that afflicts doing research in that part of the world anyway.
So just from listening, it just sounds as though it would just make sense to just put a hold on this whole trial work and rather focus the attention on just prevention measures and perhaps put the trial on as more of like a data gathering in the meantime.
Well, I think that, so Tony Fauci would certainly argue that, say, forget about all this stuff. We know how to handle this outbreak. All we need are public health workers, containment, contact tracing, quarantine, yada, 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 and that's all they're sending over there. Fine. I don't think that that necessarily precludes looking at drugs and vaccines as long as we do it the right way so that we can actually learn something. What is undoubtedly true is that this will not be the last outbreak of Ebola. Now, it may be that the reasons why Western countries are getting so hyped up about this is not so much their dear concern for West Africans who are suffering and dying, but they're concerned because it might come here. And indeed, Ebola has been classified as a, class 1 or class 4 bioterrorism agent.
Yeah, level 4.
So there's reason to be scared, I guess. Things are really getting ramped up. And the NIH is getting ramped up, and the CDC is getting ramped up, and everybody's getting excited. But even if their motivations are suspect, the point is to develop effective interventions, effective pharmaceutical interventions for Ebola. And the only way to do that is if we can actually develop them and learn something from them. And giving unproven medications to people simply because we have them and we have to do something is not going to permit that. And indeed, the history of medicine is rife with mistakes where we've given something to people out of compassion and have heartfelt empathy for their situation and have killed them instead. So I think we have to be very careful about this.
Other questions or comments?
How many
Yes.
people die a year together? All of it, do you know? You know, either all the malaria,
Is there
HIV
Africa?
in Africa,
So
yearly.
800,000 deaths per year from malaria?
In Africa?
Yes.
800,000.
Uh-huh.
Many of them children.
2 million per year from tuberculosis, 2 million per year from AIDS.
This is just
That's all of it.
all the time.
Well, that's global.
Global.
Uh-oh.
But in Africa,
In Africa,
is what?
The substantial majority.
40 or 50% of that, at least?
Uh-huh.
So this is just the background.
Yeah.
So it's horrible. So the fact that 4,000 people or 3,000 people have died of Ebola, I am not discounting that. That is horrible. If that happened here,
Oh, yeah.
the whole country would fall apart. But the fact is that every single year, hundreds of thousands of people are dying of potentially preventable as well as treatable diseases. And where's all the hype? How come the president and the World Health Organization are not getting on TV? Nobody asked me about that at WUNC this morning. It was me who had to bring it up.
You have a question?
Well, I actually had a two-part kind of question. So, my first question is just a general knowledge question. Is there funding right now for like a clinical trial at all, or is there any kind of?
I bet the drug companies are counting out their pennies as we speak.
Okay.
I think there's more. The NIH is devoting money to this, and all of these drug companies have dollar signs in their eyeballs right now.
Okay. Because it was just interesting to me because when you were talking about motive, and we just started it in Dr. Broverman's Africa Development and Emerging Diseases class, we just started talking about how oftentimes the ethical issue is that in Africa we'll conduct a trial, and the real people who benefit from that are going to be the people in the East who can actually afford the vaccines. So I was just wondering how much you felt that the reason that we haven't really been. There's been a lot, when Obama came forward and said that we're going to send over supplies and people and just try to contain it, but there hasn't been as much focus on actually trying to have a trial that could affect this epidemic now. How much do you think has to do with the fact that, as you said earlier, there isn't, yes, Ebola, people are afraid it'll spread, but the chances of it spreading aren't that much. How much do you think it affects, how much do you think there isn't a trial because the West isn't as worried about themselves?
So I think prior to a month or so ago, the few companies who were working in this area were laboring in somewhat of obscurity. But now, so that Chimerix company that I mentioned, I think I read in the paper that their stock jumped 20% in one day, simply because they killed a virus in a test tube. So I'm a cynic about many of these things. I think that Ebola has reemerged as a threat to the first world and not just an endemic threat to the third world. And that's why there's so much hype. Will people, if effective medications come out of this, the vaccine comes out of this, will it potentially benefit people in the third world where this virus lives? Possibly, if we do this the right way. Meaning that if there is funding available to make it available, such as, for instance, many HIV medications. Finally, it's come to the point where they are now mostly affordable in sub-Saharan Africa.
Yes.
Because of concerted efforts. But how long did it take for them to penetrate? I will say that the World Health Organization's regulations, as I understand them for clinical trials by Western companies in Africa or in resource-poor countries, demands that medications that are tested in those people have to be tested for diseases that afflict them. And there have to be efforts to be made that if the drugs are found to be effective and safe and are approved, that they must be made affordable to those individuals.
Okay, so it must be.
That's part of the deal after some of the catastrophes and disasters in the past.
I just have to tell you that I am an employee of Chimerix.
Oh, okay. So,
And I'm responsible for the internal audit function.
okay.
And I can just say from personal knowledge, it was a small company, 65 people or so. We're virtual.
Congratulations.
Thank you. And I would say that the majority of the folks that I work with are excited about the prospect of helping folks.
I think it's
We're very nervous about this drug is our baby. We've been working on it for a dozen years. It's indicated mostly for cytomegalovirus, adenovirus. And this was just a curiosity that somebody in the lab pursued because of the crisis. I don't know what direction it's going to go in, but I can say that we definitely want to do the right thing. So I appreciate your talk.
I think that, and mentioning your company, I think that so particularly this is live streaming, maybe the stock is going up another. I'm not a shill for the company. From what I can understand, I think there are lots of companies that are doing a couple of things. One, looking at drugs that are they've been investigating or already on the shelf for other stuff. I believe that has been mentioned, actually, I believe this was published, that somebody was maybe, I don't know if this was just theoretical or a hallucination, that somebody was thinking actually some statin drugs might be effective. So that not only, my understanding that hypercholesterolemia is the least of the problems in Western Africa. So they can get their cholesterol treated and maybe get, but the problem with the repurposed drugs that are already approved is why in the world would you try and find out if they actually work or not, because you can just buy them. Nobody's going to want to be in a clinical trial. And that we've had that problem in the United States. And Duke was involved in some of that stuff many years ago, for instance, with clinical trials for stem cell rescue, myeloablation, bone marrow transplant for advanced breast cancer, which people wouldn't sign up for the controlled clinical trials because everybody was convinced it worked.
Sure.
Well, Phil, thank you for a great discussion.